Kia ora everyone, and welcome to our Goodfellow webinar this evening on depression in the elderly. This webinar is kindly supported by White Matter DHB. I'm Dr. Louise Kugler from the Goodfellow unit, and tonight I'd like to introduce our expert speaker, Dr. Sachin Jauhari. Sachin is a consultant psychiatrist at North Shore Hospital in Auckland. He is the clinical director for psychiatry of old age at White Matter District Health Board, and he's an honorary senior lecturer at the University of Auckland School of Medicine. Sachin's special interests include assessment and management of severe mental disorders in hospitalised elderly patients, mental capacity, and medical ethics. So I'd now like to hand over to Sachin. Kia ora, Sachin, and welcome.
Kia ora, Louise, and thank you everyone for having me today. Good evening, everyone. And thanks for the introduction, Louise. I'm going to present on depression in the elderly specifically. And a lot of you would have already seen and are seeing people with depression in your practices and in your clinical work. And it's good to say, and I'm thankful for that, is that the treatment and the management and assessment of elderly is not much different from the young adults. But there are subtle changes in etiology and in treatment, as you guys already know. And so we will talk about those too. So Cicero had it right. If somebody looks superficially, old age is full of reasons why somebody would be depressed. There are medical issues in old age. There is, to a certain extent, loss of purpose. The way our society is constructed, inherently, in quite a few societies, elderly people have, or at least perceived, lack of worth in the society. And of course, there are other financial and social reasons which increase the risk of depression in the elderly. Having said that, there is no clear evidence that elderly suffer from more depression than young adults. But at the same time, there are subtle differences and certain complications, not least because of medical issues in the elderly, which hampers the treatment to a certain extent. Quite a few people in New Zealand have depression in old age. This data is from the MAGPIE study, which was done in general practice, and it is much higher in residential care. Some studies have suggested that the prevalence of depression in residential care is up to 30%. That's a third of residents in residential care. It is quite easy to be lonely amongst a lot of people. And I'm sure that some of you work in residential care settings. And if you think about it, it's not very hard to lose sense of purpose, sense of autonomy in residential care settings. Late life depression adds on to the healthcare costs substantially. We, in our general hospitals, are seeing quite large numbers of elderly people getting care in our hospitals. And for people with depression, it is very common for them to not look after themselves and not look after their other healthcare needs, which then leads to representations in hospitals, and not only leads to more hardship for the patient, but also considerably increases the healthcare costs. There is quite clear evidence that depression increases the risk of multiple medical illnesses, and especially in the elderly, cognitive impairment is a big one. In fact, severe depression in the elderly, to a certain extent, predicts cognitive decline down the line, and remains one of the prominent risk factors for developing dementia. And there is a bidirectional relationship between depression and vascular syndromes. And we know that cardiac or cardiovascular illnesses certainly increase the risk of depression. Strokes, for instance, have a very high incidence of depression post-stroke. And it is bidirectional. So people with depression also have poor cardiovascular outcomes. There are medications that can cause depression or mood changes. Now people talk about beta blockers, but in clinical practice, we don't tend to see a lot of cases where beta blockers are affecting a person's mood negatively. But we do see effects of corticosteroids on mood instability quite often. We have also seen quite a few cases of people on levetiracetam, which is an anti-epileptic drug, leading to quite severe depressive symptoms and psychotic symptoms as well. And at times we have undertaken to change a person from levetiracetam to a more conventional anti-epileptic like sodium valproate in hospitals. It is also not very easy to diagnose depression in the elderly, and that is because of multiple factors. One of the bigger one is that there is, especially in the cohort that we are talking about of elderly people, there is a seemingly reluctance to discuss emotional problems. And again, this is somewhat of a socio-cultural issue. Then there is stigma of getting involved with mental health services or suffering from a mental illness, particularly in this cohort. There is also other complication, and that is of other medical comorbidities that can affect diagnosis. So, for example, in people with dementia, it is very common to see that some depressive symptoms are automatically attributed to apathy, which is, again, a big part of cognitive impairment. So it makes diagnosis much more complicated. So there are certain, people have tried to classify what they see clinically in old age. And again, like I mentioned before, depression is depression. It is more similar to the depression in adults than it is different. But there are certain subsets that become quite apparent once you start practicing in old age. So I'll mention a few of them. So agitated depression is not uncommon and also is of concern because of the agitation and associated anxiety, it does present a higher risk of suicides. The picture that we see is of a person who is profoundly depressed with probably poor appetite, poor sleep, and also a really uncomfortable feeling that they just cannot rest. And that comes from underlying anxiety, and that very likely adds on to the risk of suicides. Agitated depression in the elderly can easily be confused with delirium, and especially hyperactive delirium, where a person can be agitated or unsettled. Of course, it can be confused with mania and anxiety on its own. But agitated depression needs immediate attention, and we have used multiple strategies to combat and treat agitated depression, at least in inpatient settings. And we will talk about that a little bit later. Psychotic depression is a common entity even in adult patients. And in general, a rule of the thumb is that psychotic depression means that the depression is severe, with also psychotic features. The psychotic features can be subtle in old age. You can have prominent expressions of guilt. For example, I'm a burden on society, I'm a burden on my family, and to a certain extent, if you don't look carefully, they can be easily normalized. But if looked carefully, a lot of elderly people with severe depression have these sort of feelings at quite significant delusional intensity. We also see higher levels of worries about health, and also quite a lot of GI symptoms associated with depression. And again, anxiety remains quite a big, prominent add-on to depression, and a very uncomfortable disorder to have, anxiety. This is the other subset that we have noticed in elderly people. And we know that quite a few, almost a third of elderly with depression have deficits in cognitive testing. Now, some of that quite relates well to the hypothesis that depression is quite a significant risk factor for dementia. So it is not unusual to see people with severe depression with severe cognitive deficits. And I can easily recall a few cases in my clinical practice of people with severe depression who have been misdiagnosed as dementia. And they have improved down the line for a variety of reasons, and then we had to reclassify diagnosis. So it is very easy to mistake severe depression associated cognitive impairment with irreversible cognitive impairment of major neurocognitive disorders. There is also quite significant psychomotor retardation or slowing that we see in this subset of patients. And there's a flavor of suspiciousness, of paranoia, which is compounded by the cognitive impairment in elderly and slowed down processing speeds. So the elderly, when they are presented with slightly stressful situation, who are already in a depressed state, they are not able to perfectly and accurately assess the situation in their brain. And that leads to suspiciousness and further increased levels of anxiety. There is some evidence that executive dysfunction, and when I say executive dysfunction, I mean deficits in planning, in execution, in set shifting. These do predict a poorer response to treatment in the elderly. And if you look at literature, you will generally find that the treatment of depressive syndromes in the elderly can be quite tricky, and the outcomes are not always as good as you would expect them to be. Then there is this inflammation hypothesis, which says that as people get older, there is immune dysregulation, and that contributes to the etiology of late life depression. And the hypothesis is that aging inherently leads to increased pro-inflammatory changes, and they result in disruption of communication, immune communication in the brain, and subsequent effect on nerve growth and regenesis and nerve senescence. And then there is some other evidence about beta amyloid accumulation, which also predisposes to late life depression. But I guess this sort of thing is considerably confounded by comorbid development of cognitive disorders in people with abnormal amyloid beta accumulation. And then this is a biggie, vascular risk factors in the elderly. And as you guys are very well cognizant that a large number of elderly people who attend general practice, but also hospitals, have coexisting cerebrovascular risk factors. They have active cerebrovascular cardiovascular diseases. And it is very biologically plausible that if your organs in the body are not receiving adequate perfusion because of atherosclerotic changes or other sorts of cardiovascular pathologies, it is only fair to assume that your brain will suffer as well. And what it really means is that in human brain, you have nerve projections which connect one part of the brain to the other. And there is this continuous information transfer. And there are these multiple projections which interact with each other at the same time. And these projections are theoretically disrupted when there is a focal ischemia in the brain. And again, it is very biologically plausible that multiple hypoxic insults to the brain would lead to increased risk of development of depression. Just as an example, this is a CT scan of an actual patient of mine, and it actually looks much better on a FLAIR MRI. You see those white patches just next to the ventricles in the brain. And this is reasonably advanced vascular illness in the brain. These are white matter hyperintensities. And as you can see from this picture, they have become more confluent and they have joined together to become a continuous white sort of a band around the ventricles. And there is quite good evidence to suggest that people who have a higher level of white matter hyperintensities in the brain have a much higher risk of developing late life depression. And again, I would like to refer the audience back to the original idea that ischemic foci disrupt neural projections in the brain and lead to neuronal dysfunction and subsequent development of not only depression, but other age-related cognitive syndromes like dementias, like vascular dementia specifically. Vascular depression is much easier diagnosed when you have a person who has a significant cardiovascular morbidities. They also have detectable cognitive impairment. And unfortunately, vascular depression does mean that the response to antidepressant treatment may not be as good as you would want it to be. But then again, when you look at statistically elderly population and their neuroimaging, a large number of people with white matter hyperintensities do not have depression. A situation not very different from the fact that only a small number of people who smoke develop lung cancer. Indeed, the risk associated with white matter hyperintensities is more complicated than it appears to be. As I mentioned earlier, a lot of medical illnesses are associated with depression. A lot of medical illnesses are made worse by depression, and vice versa. It is very common to see depression in people with Parkinson's disease, in dementias itself, cancers, and like I mentioned before, stroke and cardiovascular syndromes like MI. And again, I mentioned this before, that there is a bidirectional relationship between depression and cardiovascular outcomes. And those with major depressive illnesses have poorer outcomes in cardiovascular syndromes. This is what the studies show, that up to a quarter or up to a third of people in residential care facilities can have depression. But I worked as a community psychiatrist before working in inpatient in our Takapuna catchment for many years. And this is not far off the mark. A lot of people in residential care have depression. And in a lot of people in residential care, depression is underdiagnosed and not easily identified as well. I think all of us must have read papers and have had a knowledge of this fact that depression in late life significantly increases the risk of that person developing major neurocognitive disorders down the line. In fact, there is a school of thought that believes that depression actually makes a prodrome of an emergent major neurocognitive disorder. And in another way, there is depression which is present in dementia as well. So people with standard common dementing illnesses, for example, Alzheimer's disease, can also suffer from depression. And unfortunately, again, Banerjee et al. Did a good study on this from London. And the antidepressant use is not as effective as one would like it to be in people who have dementia and who develop depression. Suicide remains a high-risk factor. It's depression. I think everybody should always think that depression is an illness with a significantly associated mortality to it. And as you can see from my first point, that older patients make significantly fewer number of suicide attempts, which potentially means that they're making high lethality attempts for suicide. And many older adults who eventually end up committing suicide have visited their primary care physician very close to the time of suicide. So that's an opportunity that we should always be on the lookout for. And it's not always easy. I completely understand. In the elderly, there are other factors that increase the risk of suicide. And not only it is the depression itself, but there are associated factors. Like I mentioned before, there is significant level of guilt because of sociocultural factors. Then there is physical illness burden. Sometimes elderly with chronic pain might feel that life's not worth living, not only because of depression, but because of significant pain as well. There is social disconnectedness increasingly we are seeing in societies, which is not helped by events like COVID-19 at all. And then there is bereavement. When you are in that age group, you are attending funerals all the time of close friends and family who are dying. So the death, that specter of death is always in front of your eyes. And hence, it does increase the risk of suicides in the elderly, and should be taken very carefully, and immediate help is ideally sought for people who are in the elderly age group with clear suicidal ideation. There is a bit of an urban legend that people who are very depressed and they are so slowed down psychomotorically that they are just unable to harm themselves. And once you start treating their depression and they get a little bit better, then the risk increases. Now, there are no clear studies which show this phenomenon, but I have personally seen a phenomenon in at least 2 or 3 cases. So that is something to be aware of. And a lot of times, elderly, as they're getting better from depression, don't realize that they're getting better because the psychic component is still there. But objectively, you can start seeing that the person is getting better. They get sped up a little bit. They're not as slowed down. Their appetite, sleep, that improves. And then slowly, self-realization also comes in that their depression is improving. The cognitive symptoms, however, do tend to lag a little bit compared to the actual mood symptoms. So it might take a little bit longer for cognitive symptoms to improve. Again, COVID-19 has led to major disruptions in our society, and it's not an understatement if I say that COVID-19 has been a single major disruptor in the life of elderly who are living in the community. It has increased isolation. It has disrupted contacts with families. It has led to increased feelings of vulnerability. And as a silver lining, what we have also noticed is that our predictions, how bad it was going to get from a mental health perspective, I mean, it has gone bad. It is not great at all. But we have also seen studies showing significant amount of resilience in the elderly, which is very positive and a very heartening observation that we have made. Again, long COVID, as you all know, is a very topical issue and has led to potential increase in depression in the elderly. I won't go too much into workup. I think we just, this is what we usually do, but it's just standard workup, standard bloods, electrolytes, full blood count, general chemistry, a cognitive screen if you can. It is always tricky because people can have poor cognition because of depression, so it may not be an accurate result. Collateral is very important because sometimes the elderly people, because of cognitive impairment, are not able to give you a good history. And then again, midstream urine, very high incidence of urinary tract infections in elderly females. And again, ECG is always a good idea because it helps us choosing an antidepressant and keeping track of potential side effects when we start titrating antidepressants. And at least in the elderly and at least in our inpatient unit, where we have severe depression most of the time, as opposed to milder forms of depression, we always do neuroimaging. We always get a baseline CT scan, not only to rule out if there's any other noxious process going on, but also almost as a baseline to compare it down the line if we see emergent cognitive impairment in the elderly. This is actually a very understated list of differential diagnoses of depression in the elderly. You could potentially include any medical illness in that, which would affect the diagnosis and confound the picture. But these are one of the big ones that one should look out for. And delirium is again a big one. We did a study on delirium I was part of in North Shore Hospital some years ago. In fact, when I was a registrar, and we did find that a lot of delirium is under-recognized, especially in general hospitals. So always good to keep a lookout for serious disorders like delirium, because they need to be reversed and underlying causes need to be addressed. I just wanted to quickly mention about bereavement, because like I mentioned before, that bereavement is a phenomenon that becomes increasingly common as you get older, because your cohort gets older with you, and there are increased risks of people dying who are close to you. And very often it becomes harder to differentiate between bereavement and depression, and what at a lot of times might be both. And a good rule of thumb at that point would be to look for functional impairment. If there is persisting and sustained functional impairment in someone after bereavement, then it is highly suspicious of a person having developed a depressive disorder, and definitely needs to be looked into for potential treatment options. There are multiple strategies for treating depression, and I have gone through the BPAC guidelines, which are available to everybody, and are a very important source of consultation for people and my colleagues in general practice. These guidelines are very good, I must say, and they're very sensible guidelines. And I won't really be able to tell you anything especially amazing over and above what BPAC says, because we do a lot of sometimes unusual and things in patients' treatment for depression when it gets really tough in treatment of certain cases. But obviously those things are not recommended to be done in general practice, and of course they cannot be done in general practice because the resources are just not there. So antidepressants in at least moderate depression, there is a place for psychotherapy only in mild depression. There's good evidence for cognitive behavioral therapy in that. But for moderate to severe depression, we would recommend that an antidepressant is tried. And of course, even for mild to moderate depression, if the patient is keen, well informed about antidepressants, and there are no red flags medically, then certainly antidepressants can be considered in mild to moderate depression because of its significant positive impact on improving people's quality of life. There is no specific antidepressant class that is better than the other. And unfortunately, it means that we have to tailor each antidepressant to each individual, depending on the actual flavor of the mood disorder that they have developed, the genetic predisposition, comorbid factors, and medical illnesses as well, and potential issues with other medications that the person is taking. I would go down a little bit in the next slide about individual antidepressants. But then again, if the individual antidepressants do not work, then augmentation strategies are suggested. So for example, if a patient comes to you in general practice and you have considered psychological therapies and you have reached a point where you are ready to consider medication, then I'm sure that one of the first line medications that most of the people would be thinking of would be an SSRI like sertraline, citalopram, or escitalopram, or even paroxetine, which is pretty good in anxiety, I must say. But also some people might even consider drugs like mirtazapine, which has a favorable side effect profile because it causes sedation and it increases appetite, which leads to an overall feeling of well-being in people who are depressed. But it is also well tolerated in the elderly that we have seen in our clinical practice. But as I said before, that SSRIs remain the first line of treatment in primary care, also because SSRIs have a good effect on anxiety. Mirtazapine is a good antidepressant, but I would hazard that SSRIs are probably overall better in treating anxiety than mirtazapine is. Augmentation strategies can, of course, be tried in the community. They obviously mean a little bit more of complexity, as you can imagine, and the follow-up can be patchy in the community. So, for example, if you look at guidelines, there is very good evidence for lithium in augmentation of antidepressants, and we regularly start people on lithium in our inpatient units. But of course, in the community, a close monitoring of their lithium levels is not as tight as what we can do in inpatient and when we have community teams involved in more severe cases of depression. There is some evidence from Tarragona about augmentation with nimodipine in vascular depression, and it again is biologically plausible that you're using a beta blocker. Potentially increases perfusion, but we are not using that in our country, and I'm not sure whether I'm sure that nimodipine is not available in New Zealand. Also, other augmentation strategies that people have tried before in other countries is with T3, which is triiodothyronine, which is just like T4, thyroid hormone, but it's again not available in New Zealand. In general, treating depression in the elderly, go low and go slow. It's always a good idea to start slow. In SSRIs, a lot of times people can experience a transient increase in anxiety and a bit of feeling feeling odd. And in a lot of people that passes away after some time. So it is worth persisting with the antidepressant if people have mildish side effects like these. As you can imagine, the metabolism in the elderly is slower, there's more fat, lipophilic drugs tend to accumulate, and again, people are on different kinds of drugs, which can lead to medication interactions as well. So we have to be careful with that. As I mentioned before, first line remains SSRI drugs. They are generally safe with good efficacy, and people really respond well to SSRIs. And it's a good idea to keep eye on a few things, like, for example, QT intervals, especially for drugs like citalopram and escitalopram. There is a black box warning if you have concerns about a person's cardiac status and there's a long QT syndrome, for instance, then it's probably the best idea not to try citalopram and escitalopram. Then sertraline is probably the safest drug if people are worried about cardiac side effects. Bleeding risk is obviously increased with SSRIs because red blood cells have serotonin receptors on them. And because of reuptake inhibition, it affects the bleeding time. And of course, the sexual side effects, which quite a few of you would already know that are quite common with SSRIs and potentially lead to discontinuation in quite a few number of cases. We've talked about mirtazapine. It can cause constipation and edema in some people, so a good idea to keep a lookout of these drugs. And venlafaxine, I haven't really seen a lot of venlafaxine being tried for the first time in the community. It is, and there is a little bit of worry about potential increases in blood pressure in people with venlafaxine. But in my practice, I've realized that venlafaxine can be tried in the community as long as people do maintain a careful oversight of blood pressure and hyponatremia, although the risk of hyponatremia with venlafaxine is slightly lower than SSRIs. Tricyclics, I know, have been very popular before, and they're quite efficacious as well, but there are significant risks associated with tricyclics, including cardiotoxic side effects, especially in overdose. And again, anticholinergic side effects, they increase sedation, risk of falls, and can also worsen cognitive function. And again, constipation is a problem with any drug that has an anticholinergic side effect. We have talked about these, and there is good evidence of trialing bupropion as an augmentation strategy and also as an initial treatment strategy. I think the uptake has been quite low because bupropion was not subsidized for depression until recently. So I think we are going to see more use in that. We are certainly starting to use a little bit more of bupropion in our inpatient practice. And again, there is some evidence of using antipsychotic agents to augment antidepressants. But again, the evidence is middling. And a lot of times you end up hidden trial sort of thing. But aripiprazole does have reasonable evidence of augmentation of SSRIs. There's also some evidence with methylphenidate, but again, methylphenidate has its own issues, appetite suppression, affecting sleep, and we don't usually use methylphenidate in our practice for depression. I would really like to talk about just quickly about ECT. I have a few more slides about psychotherapy, but we know I've already talked about psychotherapy, that CBT has the most benefit. And again, psychotherapy is a tricky one. It's not easily available in public system because of the amount of time it needs and the amount of demand there is. And we obviously have poor resources. We cannot employ psychologists easily in public system. And it is not very easy for people to access psychology, but there is evidence for CBT and some evidence for other modalities of psychotherapy. But again, if you think about it, I think it is the big part of psychotherapy is also the connectedness with another person, which significantly improves mental well-being in some people. So ECT remains the treatment of choice for severe psychotic depression with catatonia. And we fairly regularly use electroconvulsive therapy in North Shore Hospital and all the other DHBs in Auckland with fantastic results, I must say. And we have used it primarily for psychotic depression, but we have also used it for treatment-resistant cases of mania and schizophrenia. And of course, with severe cases of catatonia as well. It has got really high response rates. I mean, I don't want to overstate how effective ECT is. Unfortunately, it has received very bad press over the last few decades in the media, in Hollywood, and there is also a very vocal anti-ECT, anti-psychiatry movement, which has hindered the use of ECT. But it remains a life-saving treatment for us in secondary care. And we frequently get people who stop eating completely, and we have to resort to ECT, and we see extremely promising results with ECT. Again, the risk with ECT is primarily of the risk of anesthesia. There is not really one condition where ECT is completely contraindicated, but things like increased intracranial pressure and increased and intracranial tumors, recent stroke does rule out ECT in cases. And again, the risk of relapse remains high after ECT, and we regularly use lithium as a prophylaxis for relapses in depression after people have had ECTs with good results. And there's good evidence for relapse prevention post-ECT with nortriptyline and lithium. The side effects are generally mild. We don't usually see any severe side effects. I personally have not come across one episode of a serious side effect in ECT. I regularly administer ECT. There are incidents where people can get asystole during the seizure, but it is usually short-lasting, and people recover without any problems. Sometimes we see post-ictal delirium. We use midazolam in those cases. And in overall, in general, ECT remains a very, very strong and effective treatment. Again, I don't want to not stress on the social factors that can perpetuate depression. Appropriate home supports, which is easy to say, but it's very hard to actually institute for people who are living on their own. There are barriers for the elderly. A lot of elderly don't drive. So there is lack of, as you know, public transport is an ongoing issue in Auckland. So for them to go out and mingle with other people is not as easy as it is for people who are driving or who are younger. We use community support workers for people with depression who are with our community teams, and they are highly appreciated, and they do help outcomes in people. They set up goal-directed activities for them. And of course, in the end, some ongoing research on some really interesting substances, and I use the word substances quite specifically because we're talking about drugs like LSD and psilocybin. Ketamine is already in trials, and we have patients who are receiving ketamine with good results. It is quite promising because ketamine is one pharmacological agent which is quite quick in acting as opposed to other antidepressants. For quick action, we really only have ECT right now. So ketamine is a promising development, and we are hoping to see it in regular practice in upcoming times. LSD and psilocybin are in early stages of development and early stages of trials in animal studies as well. As some of you might know that there is a history of using LSD in depression and withdrawal syndromes like heroin withdrawal and alcohol withdrawal. Unfortunately, the research on LSD was completely stopped in 1967 when President Nixon banned it, and the rest of the countries followed. It still remains banned in almost all countries, so the research is really slow on drugs like psilocybin. And that brings me to the end of my presentation. Thank you so much for bearing with me. I hope it was not a lot to take in one go. Thank you.
That was wonderful, Sachin. Thank you very much. We've got many questions. I wonder if we can start with prevention. So what things should we be suggesting to our patients that they can do to prevent a depressive episode in their later years?
Sure. I should have actually talked about prevention and primary prevention in some cases as well. I think it's quite plausible to think that in elderly, vascular risk factors do remain quite a bit prominent sort of issue. And of course, other factors that can potentially affect perfusion, like hyperlipidemia and poor exercise tolerance. And I haven't mentioned that in my slides, but there is some evidence that statins actually reduce incidence of late life depression. So anything that improves lifestyle, so good diet, regular exercise, if there is untreated conditions like high blood pressure, then definitely they need to be well controlled. Certainly keep an eye on alcohol consumption, because we do notice that alcohol is not very uncommon in residential care, quite interestingly. And alcohol, I can see why it is popular in the elderly population, because there is lack of a lot of stuff to do, and alcohol isn't easier. But alcohol can lead to quite a lot of depression. So definitely limit alcohol. And also the most important thing is to, whenever people see elderly people for basically anything, just 1 or 2 sentences that, are you happy? Are you satisfied with life? Just these 2 screening questions would be great. And then, of course, if the answer is positive, then you can go to PHQs and stuff like that. So yes, good lifestyle, healthy life, definitely for prevention.
Great, thank you. There was a question about hearing loss and the association with depression. I wonder if you could comment about that.
A very, very good question, and very interesting, because I was discussing this only in our multidisciplinary team meeting today. We have quite a few people on the ward, just as an example, who are quite significantly cognitively impaired. And if you sometimes take 5 minutes out of it, and if you see them sitting in the lounge with other patients, although if you have only a 5-second look, it might look that they're sitting and talking. But if you look carefully, you could see that they're isolated. They can't really hear what the other people are saying. So hearing impairment is a biggie. And in the sense that, if you have hearing impairment, there's a reasonably good chance that you also have visual impairment as well, age-related. And so that really disrupts our connection with our outside world. So absolutely, yes. I mean, if you have hearing impairment or visual impairment, it definitely increases the risk of people getting socially disconnected and increasing their risk of developing depression.
Thank you. I wonder about diagnostic uncertainty. So you mentioned there's a lot of crossover between dementia and depression. What tools can we use, and what can you recommend to give us some clarity around the diagnosis?
Again, it's a very complex issue, and I think we in secondary care, and we have the luxury of seeing a patient for multiple times and for hours, sometimes in initial assessment. So I think it's much easier for us to actually diagnose people, and I can only imagine the amount of challenges people have in primary care in diagnoses. But I look at it this way, that if you have cognitive impairment, and so you can have cognitive impairment, you can have depression, and you can have both. If you have just the cognitive impairment, it is not difficult to rule out depression. If you're eating, drinking, if you're still engaging in activities, if you say that you're happy, then the chances are that this is just a pure cognitive impairment. However, if people see even few telltale signs of depression in people with cognitive impairment, I would actually personally suggest that we should lean on the side of maybe asking a few more questions, maybe asking the relatives that, is this what mom and dad are like? I mean, it looks like they're not doing anything. Were they more engaged 6 months ago? I would actually err on the side of caution for treatment of depression. Diagnostic uncertainty is a problem, and I don't really have a great answer. I mean, there are no simple tools that can tell us. Cognitive impairment very frequently comes with late life depression. And I think collateral history would be a very, very important tool. Again, if a person has a history of depression, a very significant family history of depression, if there are other risk factors, then again, the diagnosis of depression becomes much more likely.
Thinking about that for a moment, if we are concerned about the dual diagnosis, how long should we treat the depression for before we start wondering whether or not an EPOA is indicated?
Right. Sorry, Louise, when you say EPOA, you mean as in like to activate it and stuff like that?
Yeah.
This is a massive issue because a lot of the times, just to give you an example, a lot of people come into our hospitals who are severely mentally unwell, and they get treated, and not very soon afterwards that they are treated, they're discharged from the hospital because I just wanted to give everybody a perspective. We have 19 inpatient beds in North Shore Hospital for the elderly for 90,000 people above 65 years of age. So there's always this continuous flow of patients, and the usual guidelines are the 8-week trial with an antidepressant, and if you don't see any improvement at all, absolutely none, and then if you look at a person's history and it clearly shows a cognitive impairment, EPA can be activated. But I think there's another thing which we have been doing in secondary care, and I'm not sure whether people in primary care are aware of that. We have started activating EPAs in some cases for a temporary duration. So when we are not really sure what's happening, and there's a chance that there could be a reversibility in what we're seeing, we sometimes activate EPA for 3 months, 6 months, stuff like that, and then we reassess afterwards.
That's great, thank you, and that's good to know that we can do that for a temporary measure. I wonder about your experience with reconnecting Maori elderly with their whānau, particularly with the younger generations. There seems to be some evidence suggesting that a reconnection and a sense of belonging is particularly useful.
Again, this is, if I'm allowed to use the term, it's actually a no-brainer that increased connectivity. And I would even say that in certain cultures, it is, as an example, in certain cultures, autonomy is viewed a little bit more as a desirable thing than a social or a cohesive social connectedness, so to say. So I must say that I work on the shore, and our experience of dealing with our Maori population is actually, we don't usually see a lot of Maori patients in our practice, as opposed to what we would see probably in other parts of Auckland. I'm not, I would admit that I'm not aware of any particular research that clearly shows that, but I don't think that we need research in this. I think this is a clear and apparent thing, that if elderly people who are already feeling a bit out of place, who already feel that their time in this world is over, if they can interact with younger people, if they can impart the knowledge that they have acquired and they have gained that mana in their society, it would lead to a massive improvement in their self-image and self-worth. So I can only see positives. I can't see any negative in this.
Great, thank you. Thinking about aged residential care facilities for a moment, and you've mentioned that there's a relatively poor response to medications. Are there studies that look at particular activities that will be useful for treating depression or preventing depression, things like music therapy, group therapy, physiotherapy, etc.? As you can imagine, to design trials where you are comparing something like music therapy to something else, it's very hard to run randomized controlled trials like that. And so if you're looking for an absolute evidence that yes, we have a gold standard randomized controlled trial that tells us that aromatherapy or music therapy is better, then I would love to read that study, but there are none like that. But again, something like what you asked before, Louise, that if somebody likes music and if somebody likes a particular kind of music, I don't see any negative
in using music therapy. So when I was in the community, we used to, I was personally responsible for one of our psychogeriatric facilities in Beach Haven. And I saw a very prominent use of music in their facilities, and it definitely helps. So these adjunctive therapies are almost always useful, in my opinion. And to be honest, we don't have much to lose because we want to give it a good shot to treat a depression.
I wonder now if we can move on to a number of questions about medications. So the first one is around which SSRI, so escitalopram versus citalopram, which one would you use in the first instance?
Very recently, a trial came out. Well, it was a systematic review actually from in Lancet, and they have compared different antidepressants. So again, the heartening thing is that their findings are very similar to what the guidelines we have. There's nothing left field that we now have to consider. But as an initial trial, so if a person is reasonably healthy, there are no considerable or worrying medical comorbidities, then citalopram and both, they are pretty much identical drugs. They're isomers of each other. So you can try either. That's a reasonably good first starting point. If you have worries about cardiac function, QTc interval, then sertraline is probably a slightly better drug. I'm sure that there are fans of paroxetine out there. I'm one of them, primarily because despite the issues with paroxetine, that it can cause discontinuation syndrome because it's quite a short-acting drug, it does work really well for anxiety. So if somebody has prominent anxiety symptoms, history of anxiety, but good cognitive functions that they're not going to miss doses, then even paroxetine is probably a good idea. It can cause sedation in some people, so people can try paroxetine at night, just as a trial.
Great, thank you. You've mentioned lithium as a adjunct. There is some hesitation about using lithium in the community because of the narrow therapeutic index and toxicity. So I wonder if you could comment around that, please.
So lithium is a bit like haloperidol in psychiatry, in the sense that some people consider it quite a dirty drug. But again, we also have quite a long experience with these drugs. So it's better to know, your enemy sort of thing in a way. Lithium has very good evidence for augmentation. It, as people know, it has good evidence in bipolar disorder. For mania, it's fantastic. But it also has good evidence for augmentation. We have used lithium very often in inpatient psychiatry to augment people who are already on antidepressants. Of course, one of the advantages that we have is that a large number of these people are actually going into residential care. So we don't really have to worry about the adherence issues. We know that the medication will be given. In the community, of course, it's a bit tricky. Again, if a person is keen, well-educated, well-informed, is willing to, cognitively able, can drive, can access blood results, I will not warn against trialing of lithium. If for an elderly person with reasonably good renal function, I would suggest maybe try 250 milligrams initially at night, not twice a day, just once a day, because it used to be prescribed twice a day some time ago. But now we have realized that twice a day leads to more kidney damage in people. So if you want to start lithium, thyroid function test, GenChem, renal function test, start 250, check bloods again in 5 days. I know it's becoming too hard already, but check blood in 5 days. And I would, for depression augmentation, I would aim for a level of around 0.6. So we start worrying about toxicity in the elderly at around 0.8 and above. So 0.5 to 0.6 is a very safe and a happy place to be. And most patients will achieve that level between 250 to 400 milligrams of lithium in the elderly with normal renal function.
Fantastic. Thank you for that. Question about hyponatremia and SSRIs. How often should we be checking for this and what do we do with it?
Yeah. So I guess if you look at BPAC guidelines, and if I apologize if I'm wrong, but I think what it says is that you should carefully monitor for signs of hyponatremia. And if you see any signs of hyponatremia, for example, confusion, then you should quickly check electrolytes. I would actually suggest a slightly more proactive approach than that, because I mean, sometimes the symptoms of hyponatremia can be not very easily apparent to the families and stuff, and it can quickly become quite risky in some people. So I would suggest that if you start somebody on hyponatremia, especially if they're elderly and female, I would suggest definitely checking. So I would think that what generally happens in general practice, I'm again assuming, is that a person is seen and they're started on an antidepressant and probably are seen within the next 2 to 4 weeks as a follow-up. And so when they're seen as a follow-up, I think it would be a good idea to have an electrolyte screen at hand, just in case, because the incidence is actually higher in elderly. So, and it's good if you can find out early that the person is prone to SIADH.
Thank you. Ketamine will be new to some of us. You've commented that it increases and improves depression, but can cause such strong hallucinations, which potentially could cause more anxiety. So can you tell us a little bit more about ketamine and its role?
So ketamine, as you know, is an anesthetic agent, and quite curiously, one of the only reasons why we are testing drug like ketamine on with depression, with the good thing, well, not the good thing, but one of the advantages is that it is already licensed as a medical drug, unlike drugs like LSD. So we were just fortunate to have a drug like ketamine. And of course, ketamine is a drug of abuse. And we have known for quite some time that people who do abuse ketamine, they do experience euphoria in initial stages. And if you use higher doses, it can become a dissociative sort of anesthesia, a dissociative state. We have active trials going on in Oakland. There are patients. I think I'm not sure that anyone is in the elderly age group. I'm aware that it is in the adult age group, ketamine. So ketamine is an interesting drug because unlike other antidepressants, the onset of action is much faster. And people have considered twice a week dosage sort of thing for it. So it is quite promising with ketamine. Of course, the trials are always smaller in number, and once it goes out in the wild, so to say, then we might start seeing more side effects, like people who have cognitive impairment might get adversely affected with ketamine. I do think that the use of ketamine is going to be a bit tricky because of the abuse potential down the line. It will be a restricted drug like methylphenidate, for instance, for quite some time.
Great, thank you. And CBD oil, so this is becoming used more frequently in aged care facilities. Any evidence that it is useful in depression?
The short answer is no. There's nothing else I can add. There's just not good enough studies to suggest either way. But again, I mean, cannabis oil is not cheap currently in New Zealand, and it is not properly standardized. I'm sure that some people have found some anecdotal good effect, but I cannot, based on current evidence, recommend its use. We just don't have good enough evidence for cannabis oil. Great.
Transmagnetic stimulation, any evidence for that?
Again, very similar to CBD. So there have been quite a few studies that have shown that repetitive transcranial magnetic stimulation has a positive effect in depression, almost as good as antidepressants. Now, that's not really saying much, actually, if you think about it, because antidepressants response rates are not amazingly high. Mm-hmm. And if you consider that transcranial magnetic stimulation is not offered in public, and it is still a very, very expensive procedure. But I would like to point people to, I might be able to, I don't have it at hand, but there is a systematic review which was done in 2018 which is not that long ago, which looked at studies which have trialed TMS, and they found out that most studies were actually of poor quality. And their review concluded that they cannot suggest or recommend RTMS as a mainstream treatment. Now, I don't really want to completely outright, create a negative image about it. I think there is a bit more to be learned about neurostimulation therapies, but as yet, the evidence is unclear about TMS with depression.
Thank you for clarifying that. You mentioned thyroxine and its use with depression, that we're not doing it here, but I wonder if you could just touch on what's happening overseas and whether or not there is some evidence based for this treatment.
Yeah, so this is quite a curious thing, because we have known it for a long time. Even when I was a trainee in the UK, I remember it was a reasonably big deal. So it's T3, it's triiodothyronine, and it is a shorter acting version of T4, basically. So even in people who do not show any biochemical evidence of hypothyroidism, augmentation with T3 has shown really good results in some studies. But for some reason, it is not available in New Zealand. And and there have been questions, so if not T3, what about T4? But we know that T4 is just not as effective as T3. So it's one of those unfortunate things. And I just want to mention another thing. There's another agent called agomelatine. It's a melatonin, it acts on melatonin receptors and also other serotonergic and other receptors. It's a new drug which is being used in Europe and with good effect, but we don't have here either. So.
Okay, and when you are using T3, not in New Zealand, but elsewhere, this is when you would have normal thyroid function.
Yes. So it's in people who are biochemically normal. So it's just used as an augmentation strategy.
Thank you. Let's talk about sleep. So sleep is troublesome for many of our older patients. And then when there is depression on top of that, it can be troublesome. Tell us what we should do.
And please, and thank you very much for bringing this up, Louise, because if you notice in my presentation, I kind of intentionally kept out benzodiazepines completely. I don't think there is even a mention of benzodiazepines in my presentation, but I would like to say that they are quite important and they have a place. And again, as usual with medicine, we seems to go yo-yo between things. So there was a time when we were really over-prescribing benzodiazepines a few decades ago, and we have now reached a point where we are completely against prescribing benzodiazepines. So I think we have to be quite careful. Sleep, yes, sleep is a massive problem in depression. Sleep is already a problem in a lot of elderly people, even without depression. Their sleep is shallower. They tend to sleep, small sleeps during the day. So their nighttime sleep is not as good. And then it doesn't sit well with their expectation of good sleep that they've had all their life. So it's anyway complicated. And then they have depression, which very negatively affects sleep. So most of the time, as depression improves, and if the person has not had sleep problems prior to developing depression, you should expect improvement in sleep as depression improves. Now, again, there are certain strategies that people can employ here, and one of those would be the choice of antidepressant. So if somebody has a prominent sleep issue, I would suggest that maybe drugs like mirtazapine might be a good idea as an initial strategy as opposed to an SSRI, because SSRIs, generally speaking, are a little bit activating. So if somebody already has poor sleep, probably mirtazapine is also a good choice. Paroxetine can cause sedation in some people, and therefore is a reasonable option to try if you also want the anti-anxiety effect to come in. Now that leads us to standard hypnotic medication. Now, I know that hypnotic medications are widely prescribed in general practice. I know they are widely prescribed in hospital practice, and I'm sure people can criticize the prescription of sleep medications, but as all of us know, that sometimes there is just no other option. Without sleep, people just cannot function sometimes. So but I think we can be careful. So in the hospital setting, when we have people with severe depression, uh, our thresholds are reasonably low in prescribing hypnotic medication. We usually go with Zopiclone because it is a shorter acting drug. It doesn't usually cause a lot of hangover the next morning, like temazepam can. The only problem with Zopiclone is that it can cause quite a significant bitter metallic taste in your mouth, which is actually much more common than I thought. But in some cases where people have problems in maintenance of sleep rather than initiation of sleep, we do try temazepam. And in the elderly, we would usually start them at 10 milligrams and usually will not go above 20. So that's kind of the pharmacological treatment of sleeping disorders. I'm sure people have tried even small doses of amitriptyline, small doses of quetiapine, and I have nothing against that. Quetiapine has as a drug has a wide therapeutic index. So in small doses, as long as the person is not hypertensive, up to 25 milligrams or so, if it helps sleep and a little bit of anxiety, I'm sure it can be tried.
Fantastic. And what about melatonin?
Melatonin, yes. So we are restricted in trialing melatonin primarily because it's not funded. So a lot of people end up paying for it and they are not particularly happy about paying for a medication. The effect of melatonin is, so the effect on sleep, the perceived effect on sleep of melatonin on sleep is not as dramatic as you would get with something like temazepam or Zopiclone. But we have used melatonin in people with dementias who have a bit of a reverse sleep cycle. And what we are looking for is not really sedation, but what we are looking for is normalization of the circadian rhythm. And we have used that with some good effect. But again, we are really limited because we try melatonin sometimes in patients, and when the patients get better, they say, well, we're not paying for it. So it becomes a bit of an exercise in futility for us. But I'm sure if people are trying to avoid significant cognitive impairment because of benzos or Zopiclone, if there is a risk of history of benzo addiction or alcohol addiction, then I'm sure melatonin is a fantastic first line option in those subgroups of people.
Great. And just our last question, the incidence of depression in the older adult, is this increasing compared to previous generations?
When you say previous generations, you mean previous cohorts of older people or younger generations? Like, are you saying older people 90 years ago or? Okay, in general. So I'll comment on both basically. I think the answer to the first one, that are elderly people in 21st century more likely to be depressed than elderly people in, let's say, 19th century, then I don't know, because first of all, we probably won't have studies from that time. And I guess rates of depression in population depend a lot on what's happening geopolitically in the world. So I can quite confidently say right now that the rates of depression right now are probably higher than what they were 3 years ago before COVID happened. And again, the fact that we have an actual war going on in Europe actually is quite a worrying thing for a lot of people who have seen the war not long ago. So I think it depends on time about cohorts. But if you talk about young versus elderly, then there is no evidence to suggest that elderly suffer from higher rates of depression in general than younger people. In fact, like I mentioned before, that some studies in COVID-19 actually showed that a lot of elderly have quite a lot of resilience and have done better than what we expected.
Fantastic. Well, thank you so much for an excellent presentation tonight, and thank you to our audience for joining us, and have a lovely evening, everybody.
Thank you for having me.